Well, good afternoon, everyone. Thanks for joining us for, I appreciate the wave. Thanks for joining us for day three of our fifth annual Inclusive Excellence Week here at VCU School of Dentistry. We're in for a real treat today to have Dr. Phillips with us. She is actually a PhD graduate here from VCU. She's a dedicated public health practitioner, licensed clinical social worker, holding dual degrees in public health and social work. Her innovative research focuses on bridging the gap between social factors influencing dental health and broader structural determinants of health disparities. Her work promotes interprofessional collaboration beyond disciplinary boundaries to enhance oral health and health equity, encouraging access and alleviating care barriers for the Baltimore population. She is a member of several professional organizations, including TRIOTA, Phi Alpha Theta, the Oral Health Progress and Equity Network, or otherwise known as OPEN, the American Public Health Association, and a couple of months ago was profiled by VCU News, and there was a link to that in the advertisements that we sent out about this week. So I encourage you to read that. On a personal note, I am super excited to hear from her because some of my best friends and colleagues in oral health equity research absolutely love her and speak just volumes about her. So I think we're in for a real treat around understanding barriers to care, how discrimination influences access to dental services. Otherwise, take it away, Dr. Phillips.
Thank you so much, Dr. Smith. Appreciate, excited to be back. I'm really grateful for the opportunity to share my research and what I have spent the last few years of my doctoral work as well as my postdoc work focusing on enhancing Baltimore's dental health population. So very excited there. So we'll go ahead and get started. So, our learning objectives today are to recognize how discrimination impacts access to dental care among Black adults in Baltimore. We also will understand how fear influences the relationship between discrimination and access, really leading to those delays in seeking treatment, which we'll talk more about later. And then lastly, we'll discuss how intersecting identities, so who you are and your makeup, how that influences individuals' experiences in accessing the dental care system. So I always start with this result from the Delta Dental Survey. And the question asks, what make American adults feel confident daily? And at the highest, it's having good oral health. 67% agreed that having good oral health makes them feel confident daily. This was ranked much higher than being in shape, having clear skin, wearing new clothes. So I always start with this because I think it's important to recognize and honor that individuals do want to have good oral health. We all aspire for our teeth to be well, for us to not only have an attractive smile, but for that underlying care to be sought. So I do want to emphasize in this presentation and just in general findings, individuals don't choose negative oral health outcomes, but it's a effect or a result of kind of the environment in which we live in, as well as these other factors and barriers that we'll talk about today. So with this, the literature, we know common barriers to oral health care. We hear a lot about cost and financial hardship or the ability to afford, as well as lack of insurance. Some individuals don't have dental insurance or have trouble accessing or paying, even again, back to that financial hardship for the care or the lack of care that their insurance provides. We also see a lot of transportation barriers that are based both on geographic location, where the provider's office are held, how to get there, and even again, back to that cost, financial hardship that a lot of families face. Additionally, in the literature, it's a lot about oral health literacy. Do individuals understand the importance of dental care, what goes into oral hygiene? And a lot of that has been discussed, as well as language, education, or cultural barriers for whatever reason. Now, one barrier that I would say has been very scant in the literature, especially in terms of oral health, has been this idea of racial discrimination. So today we'll talk a lot about racial discrimination as that barrier. And the definition that we define is racial discrimination is the unfair treatment of individuals or groups based on their race. It is important to note that this can be intentional or unintentional, and it is expressed through different modes, such as disrespect, suspicion, scapegoating, and dehumanization. So, this racial discrimination, particularly as a barrier for oral health care, has not really been explored in the literature, and even smaller literature has not seen this trend in Black American adults. So when we look at the effects of racism on health, there are so many resources. We see that stress, individuals do have impaired cognitive function. We see a lot of mental health disorders, anxiety, depression, PTSD. We also see a lot of substance abuse. There have been several studies linking racism to individuals having a higher BMI or being obese. We also see a lot of studies relating hypertension, inflammation, and cardiovascular diseases. So there is so much literature on what happens when individuals are exposed to discrimination or racism in their healthcare. But what do we know about this in terms of our dental health? Because those two are very related, despite institutions and systems treating them very differently. So, with this, we know in oral health care settings, racism causes unfair treatment based on race. There's been a lot of studies that also have looked at the provider biases affecting their clinical decisions and interactions with individuals. That means whether they're going to choose to extract a tooth, whether they're going to save it, whether they're even going to refer you to a specialist or another provider that may service individuals outside their scope. We've seen discrimination actually limits and again influences their clinical decisions. We also have looked in the literature. Racial discrimination, actually, there's a breakdown in communication, and it's particularly for Black adults due to racism. So, a lot of providers are using jargon and words that maybe Black adults are not familiar with, or just the tone and the way things are conveyed. That has been expressed in the literature. We also have seen in studies that those who mistrust the system or face discrimination in other counters do typically have poorer experiences with oral health providers. So this is what we know again, but not really exploring what does this even mean? How do racism or discrimination show up in these settings? And then what does that influence long term? Are they still seeing the provider? Are they skipping to go? What is happening with those systems there? So when we look at dental discrimination and dental care utilization, we do see a lot of Black adults actually reporting higher race-based unfair treatment and less satisfaction with the dental visits compared to their white counterparts. Particularly in Maryland, we do also see that more discrimination is related to fewer routine dental visits. So there was one study that actually found that adults that reported four or more discriminatory experiences, they were 37% less likely to visit the dentist in the past year. So there is some type of utilization trend that we're seeing when discrimination increases. And then we also saw that discrimination, the emotional toll of discrimination does also reduce their dental care utilization. And for whatever reason why, again, once individuals have this experience, the impact is carried and then later affecting subsequent utilization patterns. So I always like to preface, I love to localize this. My research is based in Baltimore City. Many of you all know Baltimore for the sports, maybe the Ravens, the Orioles, as well as being home for the seafood. But Baltimore is also home to over 338,000 Black residents. The state alone ranks in the bottom 50% of dental wellness. And the top two common oral health diseases that we see a lot in Baltimore adults are both tooth loss and gum disease. And these start as early as 20, 30 years old, especially for gum disease, which traditionally you've been heard or taught about being like an older generational disease. But in Baltimore, it actually is starting very young. So in Baltimore, I would be remiss not to talk about this Black butterfly concept. So I do have on the right, I believe it's on your right, showing two maps of Baltimore. So the first map is the historical red line score. So we consider Black Baltimore, it's really a metaphor that represents how systematic inequities really created these concentrated areas of like disadvantage in urban spaces. So if you look at the, the map, in the inside, in this very high redlining zone, or the red, is actually Baltimore's inner city. And then if you contrast on the map on the far right, it's actually the life expectancy, which we're seeing much lower life expectancy within inner city Baltimore. So we call it Black Butterfly because the way that the outside of the city is mapped, you have very much affluent neighborhoods with a very high life expectancy on the surrounding areas of Baltimore. But as you move in, it kind of gets lesser. And this is where most of the red line or a lot of those inequities happen very early. So with this, when we talk about Baltimore, it's a very much, I would say, very demographic, but you do have neighborhoods in Baltimore that really face greater challenges and barriers to both healthcare, education, economic opportunities. And this map really kind of, again, in butterfly shape, which is why we call it Black Butterfly, or Dr. Brown actually coined this term, but really understanding how where we live, where we work, where we play, those social determinants of health really come into influence and impact our health. And this is also linked to our actual oral health as well. So this black butterfly concept actually is another framing for how we address and talk about the social determinants of health, because again, where you live, where you work, where you play, life expectancy and health outcomes, including oral health, really just differs where you live. So with this, this really led in my dissertation research for me to think about, I wanted to explore discrimination and how discrimination, what was the impact on the access to care, especially for Black adults in Baltimore. So my study actually surveyed 751 Black adults. We also did an interview with over 30 individuals as well. And individuals were between the age of 18 to 65 years old, and they had to reside in what we call Baltimore City geographic, which is that inner city part of the map that I showed. For our study, in terms of the gender breakdown, we actually had majority male participants, and over 69% of participants that actually did the survey, they earned about $50,000 or less each year. So we're talking about a very specific demographic that we looked. And then one of the other inclusions was that individuals had to report a history of discrimination across their lifetime. So we did not put a limit on when the discrimination experience occurred. In the event that perhaps you didn't see the dentist recently, perhaps there was some COVID restrictions, or if at any point maybe you had the experience when you were a child and then that later affected your willingness to go back and seek care. So we really just wanted to talk with anyone who identified as Black, experienced mistreatment or discrimination in an oral health care setting, and again was in those parameters of where the residual was. So when we look at the results, we had 58% that indicated that they last saw an oral health provider 12 months ago. We also had a very large portion, 33%, saying that they saw a dentist 1 to 2 years ago, which was very stalking, however, on the right. In the past year, 86% indicated that they used the emergency room for dental related issues within the past year. So that really sparked us as kind of odd that we have majority individuals seeing a dental provider about a year ago, but in the same year, they're high ED utilization. So we really wanted to kind of understand that behavior. That kind of caught us as a little off in the study. When we looked at, again, how do their experience influence the utilization behaviors, essentially what we found was that for each point increase in discrimination scores, individuals were 1.63 times more likely to have visited the dentist 2 years ago compared to the past year. So we 100% found that there was some type of delay between that discrimination experience and when they were likely to go to the dentist. More interestingly so, there was also gender difference. So for females, they were actually 72% more likely to have gone 2 years ago compared to the last year. So there is some type of emotional residual effect that women in our study actually identified compared to men. So there was some distinct patterns in care-seeking behaviors between the genders in terms of that last visit seen once reporting discrimination. We also found we wanted to look into that emergency room point. So we were curious to know, do individuals who reported those discriminatory experiences tend to seek ER usage? And of course, because of that, individuals was actually more likely to go to the emergency room for oral health care. So those with discrimination, with higher discrimination scores, were 3 times more likely to use the ED in the past year compared to those with lower scores. Now, what this was suggestive of, individuals in ED in Baltimore, most of them do not have a dental operatory. They're not prepared to treat dental pain or any dental related issues, but individuals were still seeking care at emergency rooms compared to traditional dental offices. So again, very much interested in health seeking patterns and behaviors and where they were going for care, despite knowing that the ER could not treat them. Most that they could do was provide a pain medication or a script in order to get them back to the dental office. So still seeing some, again, residual effects of that discrimination and where people wanted to go to actually get care for treatment. Additionally, we looked at some different covariates, particularly how fear influences both discrimination and if it was linked to any care barriers. So what we found was that discrimination really explained about 41% in the differences in dental fear, meaning that the more discrimination, the more someone experienced discrimination, the higher it was associated with actual experiencing dental fear. And we also saw that because of the fear, the utilization patterns were very varied. So higher fear scores were also associated with less frequent visits to the providers. At that point, we did not explore the sources of fear, but when individuals did identify, I felt discriminated, I was scared, I no longer went, we saw that fear acting as a mediator in which discrimination did influence the fear level, which also impacted the use of oral health service. So really, again, understanding that relationship between if I'm afraid where I'm going for care, I'm less likely to go for care, and now I'm leading to delayed dental visits as well. We also, too, were curious about intersecting identities, who we are, our makeup. How does that influence access to care, who we see, and where we choose? So, the two major themes, and most of this was done in qualitative inquiry from interviews, was both classism and the population was at risk, which individuals of LGBTQIA plus backgrounds. So, with classism, individuals talked a lot about economic barriers that were limiting due to cost and insurance, which we found that to be in the literature. We also found that with classism, there were significant differences in those that reported having transportation barriers and having to take time off of work, that causing significant challenges to be able to maintain provider visits. Also, a lot of individuals, over 70%, talked about a racialized poverty stigma where there was being assumptions made on their ability to pay, their ability to afford services, and the condition of their oral health just based on their social economic status and who they were in terms of their racial makeup. So there were a lot of slurs and really demeaning, derogatory remarks made by providers in attempting to, I would say, motivate individuals to improve their oral health, but instead it actually deterred them from seeking care because of that experience. Likely as well, we also explored individuals who felt discriminated against based on their gender identity, which led to a significant reluctance to seek care. There was a lot of data that reflected that providers made a lot of assumptions based on their appearance or gender presentation that affected the quality of treatment and individuals feeling comfortable to, one, engage in the dental care process, but also two, keep coming back to see that provider. Much of what we gathered, and I'm hopeful this will lead, and we'll talk about this later, into actionable steps, was that many providers was actually failing to ask for individuals' preferred names and pronouns. And because of that encounter, it really created a disrespectful and uncomfortable environment for individuals that maybe had different preferred names than the legal name on the insurance or the legal name on the paperwork, as well as their pronouns. So a lot of providers went in assuming things that were not necessarily true just because the forms were not adapted and they weren't being asked directly. So In terms of our big key findings, we really found from this study that discrimination it negatively impacts oral health utilization. 100%, we're seeing delayed care, we're seeing individuals not go in a long time frame, but also we're also seeing high emergency room utilization, which again leads to no care because they're getting a script, they're not getting the treatment or the tooth removal or the cleaning in these emergency room settings. We also saw that there are immense gender difference in utilization behaviors and patterns, how frequent someone goes and where they choose to go as well. We also see that discrimination increases fear, which in turn lead to those delayed dental visits. And lastly, that discrimination and classism really resulted in delayed treatment, increased anxiety, and poorer oral health for individuals from marginalized identities, including those from LGBTQIA plus backgrounds and those of lower socioeconomic backgrounds as well. So in terms of our conclusion and call to action, it's really important, and I can't emphasize this enough, that from this, we found that racial discrimination impacts oral health disparities and behaviors among Black adults in Baltimore. And it's really important that we think about cultural competence in addressing these disparities, but also building trust in oral health care systems, because right now there is no trust. Individuals are not going to the dentist and they're choosing to delay the care that we know that we need. It's also going to be important too in terms of a call to action is that we respect cultural norms with inclusive environments that not only enhances trust, but it also contributes to the well-being of Black patients. We saw in the study, individuals do want good oral health. We just got to figure out how to support them, respect them, and help them come in to meet that first encounter. It's also important to really collaborate amongst healthcare provider institutions, public health professionals. Is really going to be important for an equitable oral health care system. And I make this point because individuals are seeking care. We see them going to the ER. Over 86% of them went to the ER in that past year and then later delayed treatment. So it's not that they don't want treatment. We just could coordinate with systems and institutions where we know are serving the population that we need to treat to be able to figure out how to bridge that relationship. And I would also say that too, more research is really needed to refine the methodologies and to explore discrimination in these oral health care settings, which lead me to, again, how do we use here an anti-racist framework? Really looking at this framework to evaluate where do we see ourselves, whether we are providers, whether we're advocates, public health professionals, nurses, wherever we sit in a position and a seat to be able to have a voice, where do we see ourselves on this anti-racist framework, and how does that translate both into our practice, into our beliefs, into our thoughts, and how do we serve and treat others? And I use this to think about, again, next steps, postdoc research, where do I want to take this? And I think when I look at it, I look at trust in healthcare settings, because really, I think that's the foundation. When discrimination was being discussed in my pre-doc work, it was that we don't trust our healthcare or our healthcare provider, and we are scared. So I'm really curious to explore how trust in these settings really affect their access to the service, but also how these experiences influence where they go for care, who are they being seen to, and also with this, how do we develop actionable recommendations based on these research findings to be able to inform not only the dental operatory, but outside our social services, our insurance companies? How do we improve that care and access for Black Baltimoreans in Baltimore? So I am finished, and I would love to talk more and have question and answer. Thank you all for listening.
Awesome. Thank you so much. Any questions in the room, or also I will take questions in the chat for those of you in Zoom and make sure I read those out loud. So any questions in the room to start us off at all? Yes. Okay, so the question is, what gauged or prompted your focus to look specifically at Baltimore?
Sure. Baltimore for me, although I did my PhD in Richmond, Baltimore is home for me. So I am a resident of Baltimore longstanding. And I was curious, growing up in Baltimore, oral health was not something that we discussed much. It wasn't something that was prioritized. And I was curious as I was becoming in public health and social work. Why is this an issue that's separated from all other health outcomes that we're seeing? So, yeah.
Other questions online or in the room? Yeah. Have you seen issues around discrimination and fear in other locales or areas of the US, or have you had the opportunity to look at other areas outside of Baltimore?
Absolutely. I did a small study in Chicago where I did my master's research, and discrimination was also a predictor in utilization patterns in Chicago inner city. Mhm.
I'll ask a question based on, I know some of the things we've discussed. You know, I think we often talk about the emergency room utilization. And it's something that I think most of us in the professions of dental and dental hygiene and even other areas that intersect with oral health are aware of. And at least from my vantage, I think we presume when people seek care at the ED, it's because they don't have any access to dental care. And it seems like in your work, at least this population, there seemed to be quite a bit of overlap where they have had access to a dentist or a dental office, but perhaps is there room for us to think about that they're making a choice,
Mm.
almost a preference to go to the ED, and is there some rationale or theories you have behind that?
Absolutely. I think that is an important call out. I would say that individuals do have a choice. One thing we found from our qualitative interviews, it's interesting because we asked the question, was the discrimination just solo to oral health, or do you have this encounter at other like medical offices such as your OBGYN or your general PCP? And they really said that I go to my OBGYN and my PCP, despite them being of a different racial identity than I never encountered the type of discrimination that I do in oral health care settings. So I would say that individuals probably do feel more comfortable in these ED environments because they're a little bit more nurturing or they feel more welcome than they would in a traditional dental office, which I think is and raises a big insight point to that.
Any other questions in the room? What, if you can, I know you did qualitative interviews, but what are some of the types of things that participants raised as the types of discriminatory episodes they experienced in the oral health settings?
Absolutely. A lot of the manifestations of discrimination really was amplified pain dismissal. So telling individuals that they weren't in pain, or they felt that individuals reported feeling like they were misunderstood or not being heard. They often told the dentist, like, this is uncomfortable, I'm not liking this. And the dentist continued to work despite that. There was also a lot of comments made about their oral health, which were very demeaning. Well, why is it that your teeth look like this? Or how long has it been since you've seen a provider? So a lot of too, those bedside manners were not as welcoming and friendly for someone that was just, I think, reintegrating themselves back in that dental care setting.
Um, I would guess too, to extend that from your expertise. So you mentioned, you know, a question like, well, when's the last time you have visited a provider? Are there suggestions on ways that we should inquire about that? Or do you find that it's tone and context that makes that more dismissive?
I think it's tone and context. I think perhaps if it's done prior to examining or seeing someone's condition of their teeth, maybe in a survey, like some of the on the paperwork that they fill out prior to being seen. But I could imagine that if that question is being asked while you're operating in my mouth, right, I would feel a little uncomfortable and probably judged a bit based on the tone and context of that question.
Yeah, go ahead. Question.
Not well, kind of providers in school is obviously becoming a topic of them, but providers who have graduated, how can we like educate them on these topics and stuff like that if they're not coming to talk or things like that and like reach them, target them?
Yeah, so the question in the room is, you know, certainly we're in a space where we're learning about these things and growing in our skill set to be able to do this in a more appropriate manner. But how would you encourage or advise us to educate practitioners already out in the workforce that are no longer in school?
Yeah, I think I think a part of that too is done in continual education. The CEUs, I know, I'm not sure of Virginia requirement, but I know Maryland has a DEI requirement that I actually built with Dr. Fleming for providers looking to renew license. So I think a lot of that is through continual education. I would hope that providers are staying abreast and really aware of these topics as they become. I don't believe they're new issues. I think it's issues that have maybe previously been raised, but due to, I think, the dental curriculum and the education, where we can squeeze that in is a little bit tough. Yeah.
Yeah, awesome. I mean, I can answer that. In Virginia, it is not a part of your continuing education. But there are more and more states like Maryland, Michigan, several others that are beginning to require as a part of that 15 hours that you have to do every year, mandating that a certain percentage of that or a number of that is like implicit bias training or ethics training or something of that sort. Yeah. Other questions? How about questions online at all? There are a couple of comments online. Thank you for your research and presentation. It supports the need for increasing the amount of oral health professionals from underrepresented groups. Thank you for sharing your work. The odds ratio as presented shows lower ED utilization. Could you look at those results again or explain those results again?
Yes, I just actually respond to that in the chat. So
Okay.
essentially, yeah. And let me make sure it went through. Gotcha.
Awesome. Any other questions for Dr. Phillips at all? I guess I'll pose the last one to respect everyone's time. So I think everyone here knows I teach ethics and professionalism. So one of the things that I push on is like the role that we play, right? And it was interesting. I think it was last week in the New York Times, there was an article about dental fear and dental anxiety that really made it almost, to me, scarily normative. And the angle of the article was sort of like all the onus was put on the patient to figure out if your dentist is basically like anxiety friendly. Like, so here's this list of questions you could ask as you interview a new dentist or you call on the phone to see if they are a good person for you to go to. And it was like almost overly simplistic to me. Like, you know, do they listen to you when you ask a question? And it's just curious to me that we're normalizing that the onus is on the patient to find like these exceptional providers that do things like, oh my gosh, listen. And so that's just really curious to me. Like, I don't know if you have thoughts there, like the profession's just doing whatever they want. And there really isn't an onus on the profession to improve, but the onus is on the patient to do even more work to find a provider that might listen to you. I don't, does that make sense?
It does.
Yeah.
It does. And I think that's why I was curious, and I'm always interested beyond the individual level of research, because I feel like the onus and the blame is put back on the individual and the patient, and that shouldn't be the case, because a lot of what's happening is unfortunately been approved, been okay, been sanctioned by dental education. And why is it that dental education itself is, I think, difficult to make those changes, but we put it back on the individual and we're seeing the effects of that feels very, again, counterintuitive. So I'm curious as to, in terms of not only, and it's bigger than individual providers, it's the board, it's the legislative, it's the insurance companies. How can we partner together to really use the research to move the direction in that phase to also impact the dental health curriculum and how dentists are even being trained today that are coming out of dental school?
Yeah, I mean, and again, you know, my opinions are often not popular and I don't care, but you know, I can remember there are a lot of third years in here, and I don't know if you guys remember in lecture this past spring, and I don't remember who it was, but one of you basically asked, like, we are a less trained, cheap labor force that then goes out into underserved communities to provide care. with the least amount of training of anyone providing the care. So isn't it sort of cyclical in this challenge that more and more we prop up the least trained folks to go out into areas perhaps of the most need of the most training? So how does that cyclical relationship continue to evolve, if you will? I don't know if that makes sense. I don't think your colleague stated it exactly that way, but I don't know if you guys can remember. But they definitely asked, like, well, aren't we just a cheap labor force that's getting this done, like, in your behalf? Yeah.
Better incentivization for people to go out and equalize.
Awesome. So the comment is that there needs to be better incentives or more incentives to work in areas that are more underserved, right? So whether that be loan repayment, lower tuition costs, sign-on bonuses, I would say, I think even for dental education, like, we train you probably not that different than we train people in 1978, in terms of the type of, like, you go out into private practice, hang your shingle, you're going to be an owner. And I think more and more that's not the world of practice you go into. And so our model is perhaps antiquated at best. Great technology, but, like, overall, the model of care delivery may not quite match with your various practice options that you leave this place to explore, right? Does that make sense? Any other questions? Yeah. Any last parting words from you, Dr. Phillips? We appreciate this so much.
No, I appreciate you all. I'm definitely, again, grateful to be here. I think to add, we talk about a lot about dental education, but I'm also pushing and advocate for dentists to also be trained as public health dentists, public health professionals. And I believe that integration would show a different shift in terms of the practitioners and the providers and the type of work or the type of institutions they go once completing dental education. So really hopeful to see, I think, the point raised about reimbursement and tuition, things like that. I would hope that, again, institutional wise, we could make and advocate for these changes based on our findings of what our population needs are.
Awesome. That is an absolute perfect segue to our speaker tomorrow, who is the president of the National Network for Oral Health Access. She's also the chief dental officer at a large FQHC in the state of Colorado. And I know that her background is she had an MPH, a Master's of Public Health, before she ever went to dental school. And just in talking with her, she said that she felt like she had all this zeal for public health when she went to dental school, and that dental schools almost like stamped it out of her in terms of, the requirements and all the stuff that we take you through. So it'll be interesting to see how that narrative kind of extends from things that we talk about today. So please join us tomorrow, the same time. We'll be in room 3121 for those of you in person. Those of you can join us virtually. And why don't we give Dr. Phillips one last round of applause.
Awesome. Thank you all.
Thank you so much, everyone. Have a great day.
Bye-bye.